Welcome back, everybody. We'll just hopefully get our presenters up on screen into the chat room for you. Thanks, Emma. Thanks, Sarah.
Brett, can you hear me?
Yes.
Oh, you're just still in, do you know that you're in presenter mode still? You might just need to change your settings. Up the top, display settings. Yeah, there. Excellent. There we go. Great.
So good afternoon, everybody, and welcome to our panel discussion around the early mobility of patients post-hip fracture. We've chosen the theme for this panel as the good, the bad, and the ugly for fans of the 1966 Italian spaghetti western starring Clint Eastwood. Our panel are here to discuss both the individual and system enablers and barriers to early mobility. So the good, the bad, and the ugly. We've got panel members from some of the high achieving facilities in Quality Indicator 5A, Day 1 Mobilisation, including Gosford, Albany, and Tamworth. So I might ask the first question of John, our anaesthetic representative on the panel. And so, John, what does the ideal early mobility patient look like, and what contribution do our anaesthetic colleagues have in achieving this ideal?
Thank you, Brett. I think that the ideal patient would be one who is orientated to the ward and their situation, or at least there's been no acute deterioration in their cognitive function. There's no delirium. They don't have any nausea and vomiting. They've had their breakfast. They're drinking plenty of fluids. The IV fluids are down. Their urinary catheter is out, and they're motivated to get out of bed and get going. They've been seen by the acute pain service, who have checked that there's no muscle weakness, that the spinal and the fascial block have worn off, and that they're on regular paracetamol plus PRN oxycodone or its equivalent, and that the next dose has been timed for the visit of the physiotherapist. Their comorbidities have been addressed by the geriatricians, and they're adequately fluid resuscitated and not unduly anemic. And I think anesthesia has a role to play in almost all these factors. For the anesthetic itself, it's important to avoid medications which are known to be associated with delirium, and to avoid hypotension intra-op. This is becoming more and more recognized as vital in the prevention of complications post-op. And we manage some comorbidities in the acute settings, such as hypoxia, anemia, and dehydration. And this last one is one of the areas where we can have a positive influence. Postural hypertension is very common in this population and is often a barrier to mobilization. While dehydration is not the only cause, it's an important one and one that's under our control. And then lastly, we're involved in managing their analgesia post-op through the acute pain service. And these, I think, Brett, are the areas where we have most to contribute.
Thanks so much, John. Ian, I guess I might put the next question to you. And certainly the elective orthopedic world is always looking at ways to decrease length of stay. From your perspectives, are there any learnings from this that can be applied to our patients with a fractured neck or femur?
Yeah, I think so. And it's a good point, because there has been a lot of work in recent years and decades looking at getting people out of hospital sooner after elective hip and knee replacement. And a lot of people think, oh, it's a money-saving thing, and in some aspects it is, but it's also an aggressive early mobilization thing, because the problems when I started doing my training is that, you know, we would leave people non-weight bearing for ages. They'd be lying around in hospital for ages. And the DVT rate used to be very, very high, pressure injuries and other things. And we've been able to reduce that. And a big part of reducing the complications after hip and knee replacement has been early mobilisation. And I think it's even more important in a hip fracture population than it is in an elective population. And yet we haven't seen the aggressive sort of, really early mobilisation in the hip fracture setting that we have seen in the elective setting. So what can we learn? We can learn that it's possible. I mean, huge strides have been made in length of stay and early mobilisation in the elective setting, but it's just very difficult to do it. And I get frustrated on my own ward when I see people. It's difficult to mobilise them because, as John said, they've still got the catheter in, they've still got a cannula in. And it's or it's a weekend. There's not very good coverage, or nobody wants to stand them because the physio's not there, and only physios can do it. It's just there's so many sort of obstacles in the way that I wonder whether we need something like we have with elective surgery in the hip fracture setting, where we have a program like an early recovery after surgery program that gets resources put into it and targets these people, because I think that's what's going to take. Because I was surprised. I used to look at the registry and I was really happy because I could see that everyone was being allowed to fully weight bear, which is great, 95% or whatever. But so few of them were actually walking on day one, like less than half. So I think that we've got a lot of work to go, and we can apply some of the things that we've learned from the elective world to the hip fracture world.
I guess, Ian, perhaps the first thing the registry has done is to change that question. So we're now able to see, I guess previously we could see what was offered. Now we're seeing what's the actual practice is. A great change there.
Yeah, that's been an eye-opener for us, though. Yeah.
And I guess, Ian, along that lines of the sort of elective orthopedic surgery, that sort of anterior approach, anecdotally here, I guess, we seem to see those patients that are having a fracture neck or femur fixed but by an anterior approach seem to have less pain and get moving faster. Your thoughts on that?
Yeah, there's some evidence in the elective world that there's slightly better early function. And now people are applying that anterior approach. It's come across from elective hip replacement to the hip fracture population, particularly those having total hip replacement. So, yeah, I think it probably has a role, but to me, the biggest obstacle is just having people and having their, catheter out and their drip out and actually sort of getting them back to normal quicker.
Yeah, great. Thanks, Ian. I guess, Joel, we've heard from John, our anaesthetic guru, what the ideal patient looks like presenting back to the ward. Unfortunately, John isn't working today, so your patient has come back from theatre post-surgery. And I guess, can you elaborate a little for us on what patient factors are stopping you from attempting day zero mobility with this patient? Because true to form, the physiotherapist has taken off early for a long weekend and they're gone. So thoughts on that, Joel?
True. I mean, one thing I will say that our physios do a fantastic job with the wards that we have and our hip fracture patients. One thing that we do try to do here is encourage our nursing staff to get them up mobilising day one as well, regardless of physio. Physio, obviously fantastic, but there's a couple of little factors that you really need to take into consideration. Obviously, taking their vitals before they get up. So a lot of the time, sometimes patients can have a vasovagal, or their blood pressure can drop to their boots. As John and Ian were saying, essentially you've got the catheter, you've got lines in, things like that. You've also got their pain is a significant one as well. Sometimes some patients, depending on their pain levels, they're unable to mobilise or just reluctant to get up and mobilise. Another one that I've found is cognitive impairment as well. So especially even so post-op delirium, depending if we've done a general anaesthetic, spinal anaesthetic, the delirium is a big factor. Obviously, if they're not able to follow commands and things like that, it can be quite difficult to get them up and mobilising. But there are a couple of the issues that we found. But one thing we do try and do here. I've got a little thing that I do here at 11 o'clock roll call. So anyone that has had a procedure, go around and see them before 11 o'clock and make sure they're up for their meals. Trying to motivate and encourage those patients to get up. And one thing I do when I'm doing a consult for a patient pre-op is making sure that they're aware of that. Obviously, if they're cognitively impaired, making sure that they're aware that they need to be up and moving. It's ideally, it's best to be mobilizing as much as possible in order for them to get those muscles, accustomed to that newfound hardware. But more so, sorry, getting back to your question is, pain is a big one. Catheter, obviously having those lines and drains in, and cognitive impairment as well. Pain.
That's a really important point you raised there around cognitive impairment, Joel. I guess we've got the need to provide the best possible care to the patient, and sometimes the other consideration there is the safety of our staff as well. And
Absolutely.
As a physiotherapist, I guess, who's had a previous back injury, it's probably the group of patients that I'm most worried about is those with cognitive impairments. Your thoughts there?
It's more just because, they're so reluctant to, and they don't know it, but they're so reluctant to obviously follow those commands and things like that. So it does put a lot of more pressure on you to a little bit more, what's the right word I'm trying to look for? They're a lot heavier to look after and a lot heavier to try and get them to mobilize independently, whether it be on the forearm support frame. Obviously, we try not to use a Serra-Steady, but if it needs to be done, it is. But obviously, with the registry, obviously Serra-Steady isn't a no-go. We want to get them up mobilizing the forearm. I know a lot of our orthopods try and encourage the use of no forearm support frames. We want to use the pickup frame or the four-wheel walker as early as possible. Not all of them, but a couple of our orthopods try and encourage that. But it can be quite difficult, that cognitive impairment, definitely. And that you'll find, I've found when entering into the registry, a lot of the times the opportunity is given, but the patient's reluctant to mobilise.
Yeah, I guess the point that Ian raised earlier. Thanks so much.
You hit the nail on the head, Ian.
Thomas, the patient doesn't get out of bed day 0, and luckily you're there to review them early the next morning. And I guess the question we're posing to you is there a quick fix to any of the problems that Joel's mentioned, or have we kind of missed the boat with this patient?
Sometimes there's a quick fix, but I certainly don't think we've missed the boat. But if we let some of those issues drag on to days 2, 3, and 4, then I think we really have missed the boat. So really now the opportunity is to identify some of those barriers, some of which Joel's alluded to, and cognitive impairment being one of them, and formulate a plan. And I think it's hard to be too didactic about what needs to be done. I think approaches need to be individualized. And that's why it's a good idea to have a system where you are able to communicate and coordinate with other team members who are on the ward. Because now we're sort of starting to transition a little bit away from a surgical patient, but now recognizing this is a frail, older medical patient who's just had a surgical procedure. And so now these sorts of things are starting to come into play. So, look, we need to identify acute problems, which could be a delirium on top of dementia, as well as a lot of other medical or surgical problems which could be starting to arise. But also, I think the importance is also to contextualize this patient. And I think this is why it's important for geriatricians and other clinicians to assess and have a handle on the patient even before they've reached the operating table. Because if you've had the opportunity to understand the comorbidities and the ability of these older patients before you see them on day 1, then you're already ahead of the game in terms of formulating a plan to get them up and going.
I guess it's the benefit there of Thomas of the notification of the geriatrician or ortho-geriatrician of the patient presenting to the emergency department, so that earlier warning the better that you can be seeing these guys.
Yeah, that's right. So built into, I think this highlights the importance of systems. And and the coordination of team members within those systems. So the screening that takes place, particularly identifying people who've got cognitive impairment, who are malnourished, who and have debility-related issues, and the list goes on, is really important, because if those sorts of problems are identified early, then they can be proactively managed. And I think it's really helped in our hospital in terms of having pathways, which are a nurse-led pathway, but it helps people get onto the same page in terms of what needs to be done when, and it certainly made my job an awful lot easier.
Yeah, great, Thomas, thank you. And I guess we've talked a bit so far about the many patient factors that support or delay early mobility. In your experience, are there any system or service delivery factors that contribute to the delays in early mobility with this particular patient group?
Thanks, Brett. There definitely are. In my experience, some of the service demands that limit our ability with early mobilisation day one is our physio and nursing staff levels, and this is further exacerbated on the weekends with further reduction in staffing. It often means for our patients that they only get one attempt at physio throughout this day. We've already touched on the fact that sometimes day one mobilisation and even just sitting them out of bed can fall to the sole role of the physio. And the prolonged wait for surgery, especially when they're repeatedly fasted and cancelled, which we've already touched on in our previous presentations. In regard to our physio staffing levels and the demands that are placed on our service, we obviously have competing demands with an elective caseload with, estimated tight length of stays. We've got discharges that we need to do. And then that staffing, the physio staffing is further reduced on the weekend. So that physio has a greater caseload. The day ones will always be seen, but it means we have less time to spend with them, and they'll definitely only get seen once. It also means we've got minimal capacity to do a preoperative assessment of these patients. So we don't get to set those expectations like Joel was talking about, as you will mobilise day one. This is what to expect. And we often can't do a preoperative respiratory assessment to identify those patients at greater risk of complications. And we often don't have assistance on the weekend. So we have to rely on our nursing colleagues who already have very busy caseloads. With regards to the day one mobilisation and sitting out of bed, it definitely doesn't always happen. As Joel already spoke about, our CNCs and CNEs have done a lot of work, put a lot of time and effort into educating and empowering our nursing staff. But some of the barriers are nursing confidence. You have high nursing turnover, different varying levels of experience, especially when you have NOF fractures that sit on outlying wards. These nursing staff are not used to dealing with these patients. So in my experience, it makes a massive difference. If these patients are already up, sitting out of bed when we go to see them, the chance of us actually being able to get them to mobilise and take some steps is much greater when they're already up, they're alert, they know what's going to happen. And yeah, it gives time for that initial physiological response that they get when they get up. They get heaps of pain, often their blood pressure will drop, but they're sitting and all of those factors have stabilised. And with a prolonged time to wait for them to get to surgery, especially if they're repeatedly fasted, they're sitting there, they're deconditioning, they're getting weaker, the delirium rates are going up, the postural BP issues get exacerbated, and the respiratory complications get worse. So the longer they wait, the harder they are to get moving. I guess, as everyone has touched on, if there was a pathway where we could collaborate with our teams a lot better, I think this could be the answer to a lot of our challenges, a lot of our barriers.
Thanks, Emma. I guess listening to you talk there and the comments that Joel made earlier, maybe there's a place for a combination of the Sarah Steady being used to get the patient from the bed to the chair, and then physiotherapy involvement or physio and nursing involvement to commence that sort of mobilisation process. Yeah,
definitely.
Don't rule it out yet. I love the Sarah Steady. And then Sarah, I guess as one of the exemplar sites in this section of the hip fracture registry, you guys successfully mobilised over 80% of your patients day one post surgery. We'd be really interested to hear what you and your team have done to counter some of these systems barriers that Emma just spoke about for early mobility.
Yeah, thanks, Brett. We do lots of planning. So multidisciplinary teams, we always have that early rapid round. So you kind of get a lot of information about how your patient is overnight, whether they got sleep, how their pain's going from the nursing staff, which is really great. The orthopedic team actually come to the rapid rounds as well. So if there were any medical issues or reasons that you couldn't get them up, like you know about all of this early. Then you can plan your day so that if you are going to see the patients with that do have a lot of pain, you'd wait for the APS review to optimise the patient. In Tamworth, we're pretty lucky because we have a wardsman, and most of our patients, like unless they're in ICU, do come to the orthopaedic ward with the fractured NOFs. So we do have excellent nursing staff, and the CNC is extremely good at making sure that all of the new nurses are trained to know that to wash the patient's catheters out, get the pain relief in early so that we can get them up. I'm pro Sarah Steady in terms of space and restrictions on our ward for the first time, just to get them into a chair before you can get them up and get them mobilising. Because if they're sitting on the edge of a care wave, sometimes it's really hard to get them to stand up because the care wave is unsteady and hard to move. So sometimes we do use the Sarah Steady just as an assessment tool to see how well they took weight, whether they were able to step with the Sarah Steady and then pop them in the chair and grab a frame and go from there. But yeah, definitely a good team approach, and our consultants are pro early mobilisation. We even have one that comes in on the evening shift to do our joint replacements and walk them when we've obviously gone home for the day.
Interesting, Sarah. I remember having an anaesthetist, John, come down and help me with the day one mobilisation. Not suggesting that's should be the norm, but it certainly highlights the importance of teamwork, doesn't it?
Absolutely.
Just looking at a couple of questions that have come in, and the first one, I guess, is a comment as well as a question. So, older people with a hip fracture are older and often frailer than elective patients. Adequate time to address fears and concerns re-walking early is important. So, Emma, do you want to any response to that?
Sorry, can you repeat the question?
Sure. So, older people with a hip fracture are often frailer than our elective patients. Adequate time to address fears and concerns re-walking early is important.
Yeah, absolutely. The amount of people that are really surprised when you say, we will see you day one and we will get you up and walking, the response from the patient and the family is often horror initially. How can you do this to me straight away? But if you set that expectation and explain the importance, and it gets you home quicker, it gets you to rehab quicker, you'll regain your strength a lot quicker, and you explain them, a lot of people are really willing to get going quicker. They need to be prepared mentally. Yeah.
It leads into the next sort of comment that's proving quite popular on Slido, which is the management of expectations is important with patients and families. And should we talk more about what will occur post-surgery? And Joel, I guess that's something that you are doing with your patients regularly. Just might be on mute there, Joel.
Sorry there.
Yep, thank you.
Sorry. Yeah, so that's one thing that I do. So Monday to Friday, I go and see all our hip fractures. So anyone that comes in, usually we'll go to ED in the first instance. At the moment, we can't because of COVID, being a red zone. But generally, yes, seeing them preoperatively, not just going through mobilisation, but everything as well. Anaesthetics, the procedure itself, and just giving them a clear rundown of basically, you've fractured your hip, this is what's going to happen from this point onward, and your whole journey and the whole process to when you're being discharged. Also, as Emma touched on too, like obviously we try and get letting them know that we try and get them home independently get them home independently first. If we can't, then we go home with services and then we go to rehab. A lot of times if I start with rehab first, no disrespect to the males, but the males seem to be a little bit more inclined, but more so, you start off with that rehab, then they just think, oh, I'm not going to get out of bed, I'm just going to go straight to rehab. But you want to get them not thinking that mindset and thinking, okay, excellent, we need to be getting up day one, we need those muscles adjusting to the newfound hardware. And also as well, utilising family members as well is a really important key that I find that I do use. I try and, when I see the patient, I try and obviously with COVID's a bit different, but now that we have visitors back again, having the family there present as well, they're always a good encouragement the patient as well. But yeah, definitely going through everything from A to Z in regards to their entire journey, mobilisation being one of them, and just setting that expectation quite high, letting them know that, you know, instead of, for example, nursing staff, instead of saying, you know, do you want to get up today? It's we're going to have a shower today. We're going to get up, and that, not giving them that option to say, oh, I don't really feel like it at all, without sounding rude or horrible at all. But yeah, setting that expectation from preoperatively does help, I find, postoperatively.
A lot to be said for us all singing off the same song sheet. Ian, it's amazing the difference if the surgeon turns up day 0 or day 1 to say, and now you'll be getting out of bed. I presume that's, you know, definitely encouraged from your perspective.
Yeah, and unfortunately, we're still living in a world where patients, particularly the elderly patients, will tend to do what the surgeon says more than they do others. It's a shame, but yeah, it does help, and it's been a help in our unit to have, although we haven't had them since lockdown, these multidisciplinary ward rounds where every day there's a surgeon who comes around with the team. I think it helps to have the whole team there. You've got the head nurse comes around, your physio, everybody, just encouraging them and reinforcing with them the importance of early mobilisation. Yeah, I think it helps.
There's a comment here on Slido that having a catheter in shouldn't be a barrier to mobilising.
It shouldn't.
Patients with catheters in, but there's certainly some positives to not having a catheter in, having to walk to the toilet, isn't there?
Yeah.
And then one more on linking pain meds with their purpose, i.e. the pain meds are about getting up and moving. John, I presume that's something that the acute pain service would be encouraging also.
Yes, definitely. It's, you know, it's a balance, but patients need pain relief to get up, especially on day 1. We did a little audit of the patients who failed to mobilise last year, and pain was one of the big 4 factors where they just said it was too painful and they weren't able to get up. And then, you know, like if they get their pain relief, then they may have missed their chance because of staffing levels and people not able to come back and see them again. And so I think if they can get their pain relief, I know it's really difficult, but if they can get their pain relief timed so that they've had some before the physio arrives, then that would be fitting with my ideal patient.
Absolutely. I think that might bring us to the end of our time slot for this particular session. I'd like to thank you all for taking part in what's been a very informative panel discussion, and I think probably one that will go on generating discussion for many years to come. Thank you all.